Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Tullah, and today I have a very special guest with me in the studio, someone you may recognize from her awesome PAL sessions and absolutely captivating writing, Samra Mirza.
Hey Sarah, thank you for that very warm welcome. I'm super excited for today's discussion because we're talking about a gland that I personally believe doesn't get enough attention, the parathyroid.
All right, so before we dive into the disorders, let's set the stage a bit. Where are these guys located? What do they secrete? And why do we even care?
All right, the parathyroid glands are 4 tiny glands, usually nestled right behind the thyroid. They're stimulated mainly by low calcium levels, aka hypocalcemia, and in their response, they secrete PTH, which is parathyroid hormone.
And this PTH, it's basically the body's emergency responder for calcium, right?
Exactly. When your calcium is low, PTH jumps in and reabsorbs calcium in the kidneys, releases calcium from the bones by resorption, and helps the gut absorb more calcium by activating vitamin D. Oh, and at the same time, it makes you lose phosphate in the urine to keep the calcium levels nice and high.
So basically, the main goal of PTH is to raise calcium levels.
You got it.
Okay, so with that in mind, today we're going to talk about the disorders that can affect the parathyroid gland. We'll start with primary hyperparathyroidism, which includes adenoma, hyperplasia, and carcinoma. Then we'll talk about secondary hyperparathyroidism, usually a complication of chronic kidney disease. And finally, we'll finish off with hypoparathyroidism when there's not enough PTH.
Yep, lots to cover, but not to fret. We're here to make it easy for you to follow along.
All right, let's get started with primary hyperparathyroidism. What exactly is it?
Primary hyperparathyroidism is when the parathyroid glands start secreting too much PTH on their own without the normal checks and balances, resulting in hypercalcemia.
And who's most likely to develop it?
It's way more common in women, and it usually happens later in life, typically after the age of 50.
Is it one of those autoimmune things again?
Actually, that's not the case here. It's more of an excessive growth of the parathyroid gland. Most cases are caused by a single parathyroid adenoma, or it can be caused by primary parathyroid hyperplasia when you have enlargement of all 4 parathyroid glands. Or, the rarest but the scariest cause of primary hyperparathyroidism is a parathyroid carcinoma.
All right, so if you see primary hyperparathyroidism, you think of an adenoma first because that's the most common. But make sure to exclude primary hyperplasia and parathyroid carcinoma. And the mass or the enlarged glands produce a lot of PTH.
Yes, when there's an adenoma or hyperplasia or carcinoma, the parathyroid cell starts making PTH nonstop, no matter the calcium level. So whether your calcium is low, normal, or even sky high, PTH is still shooting up.
And PTH, like we said earlier, pulls calcium from the kidneys, bones, and gut.
Exactly. That's why these patients get hypercalcemia.
So, as we said, primary hyperparathyroidism causes hypercalcemia. We can remember the symptoms of hypercalcemia using a mnemonic: stones, bones, groans, and psychiatric overtones.
This is a very helpful mnemonic for hypercalcemia, so let's break it down. Stones refers to kidney stones, specifically the calcium oxalate type.
Of course, that makes sense because we have excess calcium.
Bones refers to bone pain. Fractures are that classic osteitis fibrosa cystica you see in primary hyperparathyroidism, which looks like a punched out lesion in x-rays.
That's because PTH causes bone resorption to increase calcium.
Groans refers to constipation because when someone is constipated, they groan because they're in pain.
The reason why these patients experience constipation is because a high calcium level relaxes smooth muscles. Smooth muscle relaxation may even delay GI motility and gastric emptying, leading to peptic ulcers or gallstones.
Exactly. And the last symptom in our mnemonic is psychiatric overtones, and that refers to psychiatric symptoms like depression or cognitive dysfunction.
So we said the mnemonic is stones for kidney stones, bones for bone pain, groans for constipation, and psychiatric overtones for depression and cognitive dysfunction.
These patients also often experience fatigue, weakness, lethargy. They may show some cardiac signs like a short QT interval and a widened T wave, or some problems like nephrocalcinosis, which is basically a type of metastatic calcification. What that means is, because you have so much calcium, it starts to deposit all around the body, and one of those places is inside the kidney.
So it really messes with almost every system in the body.
Yep.
And how helpful was that mnemonic, huh?
Maybe if you keep repeating it, stones, bones, groans, psychiatric overtones for hypercalcemia over and over again like a chant, it will become very familiar, like your own name. Let's do it one more time.
Stones, bones, groans, psychiatric overtones.
Okay, that's enough.
All right, Samra, let's zoom into our first cause of primary hyperparathyroidism, the parathyroid adenoma.
Okay, we have a 62-year-old woman coming to the clinic with fatigue, generalized bone aches, and a history of kidney stones. Her labs show elevated calcium, low phosphate, and high PTH levels. Neck imaging shows a single, well-circumscribed mass near the thyroid.
Okay, she has a single mass that looks kind of benign, and there's high calcium, high PTH, and low phosphate. This looks like a parathyroid adenoma, the most common cause of primary hyperparathyroidism. So tell us, what is a parathyroid adenoma exactly?
It's a benign tumor in one of the parathyroid glands that autonomously secretes PTH. So basically, the gland ignores the normal calcium feedback and just keeps making hormones even when the calcium is already high.
So it's like the parathyroid gland has gone crazy.
Exactly.
Is it sporadic?
Most cases are sporadic, but there's a small subset associated with multiple endocrine neoplasia syndrome, especially in younger patients.
All right, so if you see a younger patient, you might want to think of MEN syndromes.
Yep, especially if there's a family history of endocrine tumors.
Since it's a benign adenoma, it would be well circumscribed, right?
Yes, it's usually a soft, tan-brown nodule that's encapsulated and well circumscribed.
It would have chief cells because those are the cells that make PTH.
Yeah, parathyroid adenoma are mostly chief cells, often described as uniform, polygonal chief cells with central nuclei. You'll sometimes also see small nests of large, pink oxyphil cells.
So it's a bunch of chief cells that are out of control.
Exactly, but it's only in that specific area. The rest of the gland around the tumor and the other parathyroid glands are normal. That's how it's different from hyperplasia, because in hyperplasia, all 4 glands run amok.
And patients with parathyroid adenoma have hypercalcemia, so they present with all the classic symptoms that we talked about.
Remember our lovely mnemonic?
Stones, bones, groans, and psychiatric overtones
for hypercalcemia. But keep in mind that these symptoms can sometimes be super subtle at first.
So not every patient will walk in dramatically waving kidney stones in the air. Sometimes it's just fatigue and subtle body pains.
Exactly. Always have a high index of suspicion.
Did you treat them with surgery?
Yes. Luckily, removing the adenoma is usually curative. But you need to be careful because the rest of the parathyroid glands, which are normal, are kind of sleeping.
Since they're normal, they're suppressed by the high calcium that these patients have been having.
Exactly. So if you remove the tumor, you remove the source of PTH, so calcium can quickly drop.
Huh? Wouldn't the normal glands kick in by then?
Well, they take some time to wake up, kind of like you hitting snooze 5 times before finally deciding to get your life together. That's why you need to carefully monitor calcium levels post-op until the normal glands start to work again to make sure the patient doesn't go into severe hypocalcemia.
Uncalled for, but okay. So compared to carcinoma, these adenomas are more chill, right?
Way calmer. They have an excellent prognosis with surgery.
I don't know about you, Samra, but I'm feeling a bit quizzical. Let's test our knowledge with a practice question.
Okay. Describe the main histologic appearance you see in a parathyroid adenoma. The answer is uniform polygonal chief cells with central nuclei.
Let's move on to our next cause of primary hyperparathyroidism with a new patient.
We've got a 48-year-old man who presents with bone pain, constipation, and muscle weakness. His labs show elevated calcium and elevated PTH, but this time, imaging reveals that all 4 parathyroid glands are slightly enlarged, not just one. And when we look under the microscope, we see a diffuse proliferation of chief cells, and in some areas, clusters of clear-looking cells.
Wait. Are those the water clear cells?
Yes, good job.
And this isn't a single adenoma. All 4 glands have gotten bigger.
Yep, this is a classic case of primary parathyroid hyperplasia.
So primary hyperplasia is when all 4 parathyroid glands are enlarged and overactive. They start secreting too much PTH together. And just like in adenomas, this leads to hypercalcemia.
Exactly. So instead of one rogue gland, they're all in it.
Can this hyperplasia also be caused by MEN syndromes like the parathyroid adenoma?
Yes, definitely. It can happen sporadically, but it's also seen in patients with MEN syndromes, especially MEN1 and MEN2A.
So, if someone has a strong family history of endocrine tumors, or you see hyperplasia in a younger person, you should think about MEN.
Exactly. Always keep MEN syndromes in the back of your mind.
What can we see on biopsy of primary parathyroid hyperplasia?
Most of the time, you will see an overgrowth of chief cells that follows either a diffuse or multinodular pattern. It sometimes starts out as a diffuse and then becomes nodular over time. But less commonly, you might find those water clear cells, which will look bubbly and pale under the microscope because they have abundantly clear cytoplasm. In that case, we can also call it water clear cell hyperplasia.
Primary parathyroid hyperplasia would present with all of the symptoms of hypercalcemia that we talked about.
Pretty much, yeah. That's why it's really the pattern of gland involvement that distinguishes it and not the symptoms.
I'm guessing they would need surgery, right?
Yes, in most cases, you'll need to do a subtotal parathyroidectomy, which means removing 3 glands and a half and leaving behind a tiny portion of one gland to preserve some PTH function.
That makes sense. It's not like an adenoma where we have one clear mass to go in and remove, because the problem in hyperplasia is all of the glands.
Exactly, but we still have to keep half a gland to control the calcium levels. Otherwise, the patient will get hypoparathyroidism, leading to the opposite effect, which is hypocalcemia.
But how is half a gland good enough? Wouldn't they end up getting hypoparathyroidism either way because you're removing practically all of the parathyroid glands?
Don't forget that this half a gland that we're keeping is already overactive, so it should be enough to control their calcium levels.
That makes sense. All right, everybody, put your thinking caps on for another practice question before we move on to our next segment.
What are 2 histologic patterns of chief cell hyperplasia seen in primary parathyroid hyperplasia? The answer is either a diffuse or a multinodular pattern.
And don't forget that we might sometimes find water clear cells.
Very correct.
All right, Samra, what's our next case?
I'm glad you asked. A 55-year-old woman shows up with bone pain, fatigue, and she's been getting recurrent kidney stones. Her calcium and PTH are elevated. Imaging shows a large gray-white mass in one of her parathyroid glands. Histology reveals cells that look fairly uniform, kind of like regular parathyroid cells, but they're arranged in trabecular patterns, surrounded by a dense fibrous capsule. What's even more alarming is that the mass recurs after surgical removal, and she develops pulmonary nodules.
Even though the cells look normal, they're arranged differently, and then this thing came back and spread to the lungs?
Exactly. That's what tells us that we're probably not dealing with just a benign tumor anymore. This is parathyroid carcinoma.
This one's a lot less common than the other 2 causes of primary hyperparathyroidism that we talked about.
Yeah, it's very rare. Only about 1% of all primary hyperparathyroidism cases. It typically affects just one gland out of the 4, and the mass is usually larger than adenomas, sometimes exceeding 10 grams. But here's the tricky part. It looks a lot like an adenoma under a microscope.
What would that be like?
The cells resemble normal chief cells, arranged in a nodular or trabecular pattern, and they're surrounded by a thick fibrous capsule.
If the cells look normal and there's a thick capsule, how can we tell that this specific mass is a malignant carcinoma and not just an adenoma? What's the distinctive feature?
You can't really rely on the cellular features alone. You have to look for evidence of invasion or metastasis. The key is that carcinoma invades its thick capsule and spreads locally to distant organs.
So it's not just how the cells look under the microscope, it's the fact that it invades into the surrounding tissues that makes us say it's malignant.
Yeah, exactly. Wow, you're smarter than I pegged you for.
Right. And parathyroid carcinoma presents with the same features of hypercalcemia that we saw in adenoma and primary hyperplasia.
Yes, but the biggest red flags are a large mass, often greater than 4 centimeters, recurrence after surgery, and signs of distant metastasis like those pulmonary nodules in our patient.
So if there's a large mass that keeps coming back or spreads to other organs, you should be wary of carcinoma.
Yep.
When these patients undergo surgery, how can we ensure that we got the whole cancer out?
These masses need a wide surgical resection. You don't just remove the gland, you have to take a big margin around it to make sure you got the whole thing. Even then, recurrence happens in 1/3 of cases, and distant metastasis can be seen in another third.
So overall, not the best prognosis?
It's not great. That's why you gotta grab it by the throat, quite literally, and perform upfront surgery.
This brings us to the end of primary hyperparathyroidism. I'm ready for my brain to be tickled with another practice question before we shift to our next set of diseases.
You just want questions, don't you? Let's do it. What feature best supports the diagnosis of parathyroid carcinoma over adenoma? And the answer is invasion of surrounding tissue or distant metastasis. That's your most reliable diagnostic clue. Histology alone won't cut it. You need clinical and surgical evidence of aggressive behavior.
Hey, Samra, take us to our next case.
Listen to this one. A 62-year-old man with end-stage renal disease on hemodialysis complains of muscle weakness, itchy skin, and non-healing ulcers on his legs. Labs show hypocalcemia, hyperphosphatemia, and elevated PTH. His parathyroid glands are asymmetrically enlarged, and biopsy shows diffuse chief cell hyperplasia with some of those familiar water-clear cells. They even found calcification in the skin and small blood vessels.
Wait, there's elevated PTH, but hypocalcemia and hyperphosphatemia?
Yes, the hypocalcemia is likely the initial problem that's triggering the release of PTH.
So it's not primary.
No, this is a classic case of secondary hyperparathyroidism.
So essentially, the glands are actually trying to help because calcium is low, but unfortunately, they end up causing problems anyway. That's kind of what happens whenever I try to set things right.
Of course it does. But yes, usually these patients have chronic hypocalcemia from some other condition which causes the parathyroid glands to go into overdrive and produce too much PTH.
Our patient has end-stage renal disease. Could that be what caused it?
Most likely, yes. The number one cause by far is chronic kidney disease, but other causes include low dietary calcium, vitamin D deficiency, or malabsorption issues and statorrhea.
So basically, anything that drops calcium or limits vitamin D can trigger this.
Yep, but CKD is definitely the most high-yield association.
How does chronic kidney disease lead to this anyway?
Because the kidneys are not working as they should, they can't excrete phosphate properly, so phosphate builds up, causing hyperphosphatemia.
Oh, and the high phosphate binds to calcium in the blood.
Exactly, so this lowers free serum calcium, but that's not all. You know how the kidneys normally activate vitamin D using the enzyme alpha-1 hydroxylase?
Yeah, and vitamin D is important for calcium absorption.
But in the case of CKD, the failing kidneys can't use alpha-1 hydroxylase properly, so you get less of the activated vitamin D, which means you absorb less calcium from the gut.
So ultimately, this leads to low calcium levels as well, and the parathyroid glands go into overdrive and produce more PTH.
Yep, the main signal for PTH release is chronic hypocalcemia, mainly from hyperphosphatemia, but also from vitamin D deficiency.
How do these patients usually present?
Most of their symptoms are actually from their underlying chronic kidney disease. But when PTH levels get too high, you start to see bone abnormalities like renal osteodystrophy because PTH resorbs bone, and you might see itchy skin due to calcium phosphate crystal deposits, and finally, vascular calcifications.
Oh, wait, isn't that vascular calcification thing called calciphylaxis? If I was a rapper, that'd be my stage name.
From what I understand, that would require talent. But yes, you're right. Calciphylaxis is rare but super dangerous because these calcifications can clog up tiny blood vessels, leading to ischemia, especially in the skin, which may cause painful skin ulcers like we saw in our patient.
The underlying mechanism in secondary hyperparathyroidism is quite different from the ones we previously discussed in primary, so the management would probably differ as well.
Yeah, we don't usually go for surgery straight away here. The initial goal is to stop the overdrive. To do that, you either give dietary vitamin D supplements to fix the deficiency, or use phosphate binders to reduce serum phosphate.
What if that doesn't work?
In really severe or refractory cases, some patients may need a parathyroidectomy to get rid of the source of PTH altogether.
So this time, we're not cutting first. We're trying to fix the kidney calcium phosphate axis.
Exactly.
I'm getting the munchies for another quiz. Let's have one before our final segment of today's episode.
A 60-year-old man with end-stage renal disease has hypocalcemia, hyperphosphatemia, and high PTH. Biopsy of his parathyroid shows chief cell hyperplasia. What are the two mechanisms leading to the hypocalcemia seen in his condition? The answer is hyperphosphatemia and vitamin D deficiency due to his chronic kidney disease.
All right, Samra, we've talked about what happens when PTH goes into overdrive. Let's shift to the opposite side of the story when PTH goes down.
Sure. Meet our last patient for today. A 35-year-old woman presents to the ER with tingling in her fingers, carpal pedal spasms, and a recent seizure episode. She had a total thyroidectomy 2 weeks ago. Her labs show low calcium, high phosphate, and low PTH. On physical exam, she has a positive Schwastok sign and a positive Rousseau sign.
What'd you just call me?
A positive Schwastik sign and a positive Tristo sign.
Oh, wow. She's got tetany, tingling, and even a seizure. Fun times. And that thyroid surgery 2 weeks ago. I'm guessing her parathyroids were accidentally removed during that.
You're right. This is post-surgical hypoparathyroidism, which is usually the most common cause.
What happens in hypoparathyroidism?
Hypoparathyroidism is when there's inadequate PTH secretion, leading to hypocalcemia and hyperphosphatemia. Basically, without enough PTH, you can't absorb calcium in the gut or the kidneys, and you can't activate vitamin D or excrete phosphate.
And you said the most common cause is surgery?
Yep, surgery-induced hypoparathyroidism usually happens after thyroidectomy or parathyroid surgery, especially if all 4 glands are accidentally removed or devascularized.
What else can cause hypoparathyroidism?
Other causes include autoimmune hypoparathyroidism due to mutations in the autoimmune regulator gene, aka AIRE. There's also autosomal dominant hypoparathyroidism resulting from a gain of function mutation in CaSR, calcium sensing receptor gene.
This autosomal dominant mutation in the calcium sensing receptor makes the receptor hypersensitive. It thinks calcium levels are high even when they're actually not, so it incorrectly suppresses PTH secretion.
Exactly. Finally, we can have familial isolated hypoparathyroidism or a congenital absence of the glands.
So, hypoparathyroidism is most commonly after surgery, but it can also be autoimmune, familial, congenital, or due to a defect in calcium sensing. Since these patients have hypocalcemia, we should expect a different set of symptoms than what we saw in our previous cases.
Yep. Hypocalcemia can cause seizures, paresthesia, especially around the mouth and fingertips, and tetany, leading to carpal pedal spasms or laryngospasm, which may be life-threatening because the patient suffocates. We can sometimes also see psychiatric symptoms, basal ganglia calcification, cataracts, and dental abnormalities like enamel hypoplasia and delayed eruption.
So, this can really affect everything from the brain to the teeth. We have 2 classical signs seen in hypocalcemia:
Schwastik sign and Trousseau sign. Schwastik sign is when you tap the facial nerve and the face twitches. Trousseau sign is when you inflate a blood pressure cuff and the hand spasms.
You can think of Schwastik as cheek twitch to remember which one is which. And mind the way you say it.
Oh my God.
Can you treat these patients by giving calcium supplements?
Yes, definitely. The goal is to raise serum calcium and lower phosphate. So we give oral calcium supplements, active vitamin D analogs like calcitriol to help us raise calcium, and sometimes we can give thiazide diuretics because they reduce the calcium loss in the urine, keeping it in the serum.
We also need to carefully monitor PTH and calcium levels after thyroid surgery and make sure we're replacing any deficiency in calcium caused by that surgery. Can these patients recover if it's just surgical trauma, not complete removal of the parathyroid glands?
Sometimes, yes, especially if it was a temporary injury, but if the glands are completely gone, they'll need lifelong management.
I think that covers hypoparathyroidism pretty well. How about one last quiz for today's episode?
Let's do it. A 35-year-old woman develops tingling and muscle spasms 2 weeks after thyroidectomy. Her labs show hypocalcemia, hyperphosphatemia, and low PTH. What are 2 classic clinical signs that you should expect to see? The answer is Schwastik sign, or cheek twitch sign, and Trousseau sign, both due to low calcium. Remember, Schwastik is cheek twitch by tapping the facial nerve, and Trousseau is carpal spasm with blood pressure cuff inflation.
All right, that was a calcium roller coaster. Let's wrap this up with a quick recap.
We started the episode with primary hyperparathyroidism, which is either due to an adenoma, carcinoma, or hyperplasia. Parathyroid adenoma is the most common cause. You need to look for high calcium, high PTH, and low phosphate. Don't forget our mnemonic for hypercalcemia:
Stones, bones, groans, and psychiatric overtones.
Then, we covered the other 2 causes of primary hyperparathyroidism: primary hyperplasia, which involves all 4 glands, often seen in MEN syndromes, and histology may show water-clear cells. Then, we said that the parathyroid carcinoma looks deceptively normal under the microscope but behaves aggressively, so diagnosis is based on invasion or metastasis rather than histologic appearance. After that, we shifted to secondary hyperparathyroidism, usually due to chronic kidney disease, leading to low calcium, high phosphate, and high PTH. Don't forget the calciphylaxis that may occur in these patients. And finally, we ended with hypoparathyroidism, the one with low PTH. This is commonly post-surgical, presenting with low calcium and high phosphate. Look out for Schwastig sign and Trousseau sign, indicating hypocalcemia.
All right, folks, that's a wrap on today's episode of PodBites. Huge thanks to Samra for making PTH sound way more exciting and oddly hostile than I ever thought possible.
Honestly, parathyroids deserve more hype. They're tiny but fierce.
If you find this helpful, stay tuned for more episodes to aid you in your studies. Thanks for listening, and we'll see you next time on PodBites.
A 35-year-old woman presents to the ER with tingling in her finger. Oh my god, tingling in her fingers. That's crazy. Like your own name. Let's do it one more time. Stones, bones.
Wait.
Dear Sarah.
Okay.